It's May 18, 2021, and today for SEVA VentRounds, we're going to do intermittent mandatory ventilation is not dead. And you'll see a little bit about the discussion, why is it not dead? So disclosures, here we discuss particulars of ventilator modes, and there's no endorsement of any particular mode, manufacturer, or company. And if we use more of a ventilator, that's okay. We are agnostic and accept any ventilator that is available out there. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. Those are my conflict of interest as well as Rob Chatburn's. The ground rules, this is a recorded session, so keep your microphone muted, please. I may call upon members of the audience to comment, and if you want to comment, please just put a message on the chat and I'll acknowledge it. We use WebEx poll, so I'll bring it out now and then for you to come in. And for Cleveland Clinic employees, you can get a CME, and the QR code will be available at the end of the session. So as we usually do at the beginning of this, please let us know where you're joining us from. So either your city, your hospital, your country. I see a lot of people that we recognize from prior VentRounds. Welcoming Ariel Garnero, follower, Haura Halal, Jean Paul. Some of our APPs and our fellows are also connected, so welcome all. St. John's, Canada. Wow, all the way from Qatar. That's wonderful. Okay, so as you're entering that, Frederick, welcome back from Sweden. So I thought I would put a little tutorial here on what we're going to be talking about today. And essentially, as you know, a mode of mechanical ventilation is made by the control variable, which can be pressure, volume, a breath sequence, which is CMB, IMV, or CSV, and then a targeting scheme, which is the computer software that controls the ventilator or the hardware. And then finally, from there, we created this tag that helps us summarize what each one of the modes does. So today we want to focus on this breath sequence of a mode. And we try to make this very simple. The literature is filled with words that make things a little bit more complicated for all of us. And so in mechanical ventilation, there's only two types of breaths, either a mandatory breath or a spontaneous breath. To know what a mandatory breath is, a breath for which either the trigger, so that's when the breath starts, or the cycle, when the breath ends, of inspiration is determined by the ventilator independent of the patient. Meaning a breath can be triggered by a patient, but if it's cycled by the ventilator, then that's a mandatory breath. And the other way around applies too. And a spontaneous breath is for which both the trigger and the cycle of inspiration are determined by the patient, independent of any ventilator settings or inspiratory time, expiratory time, whatever. So if we agree that there's only two breaths, mandatory and spontaneous, there can only be three combinations of them, either continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. And the one on top and the one on the bottom are relatively easy. In one, all of the breaths are mandatory. In the third sequence, which is continuous spontaneous ventilation, all the breaths are spontaneous. However, in the middle one, it's called intermittent mandatory ventilation, and that means that there's spontaneous breaths are permitted between mandatory breaths. And historically, this has referred to a mode of mechanical ventilation when it was first described by Downs. That was what it thought to be. It was just mandatory breaths that were going to be occurring intermittently, and the patient could breathe unrestricted in between them. However, and actually for many of the literature that has dominated critical care for years, those studies were done with the first algorithms of intermittent mandatory ventilation. However, those have changed, and now we have described 4 types. And so those 4 types, one is mandatory breaths that are always delivered at a set rate. That's the classic IMV. The second one is mandatory breaths that are only delivered when there's spontaneous breath rate below the set frequency. The third one is mandatory breaths only delivered when spontaneous minute ventilation below a preset or calculated minute ventilation threshold. And the last one is when there's mandatory breaths that during the breath convert to spontaneous breaths. And I'll show you some examples of that. So you can see that IMV is not what it used to be for us. It's now there's different ways to implement it. And actually, Ariel Garnero has written about this and described this in his lectures too. So intermittent mandatory ventilation, there's 4 types, and I put them here just to make it with some examples. The type 1 is mandatory breaths are always delivered. And the spontaneous breaths can occur at any time. And this is the classic IMV. And actually, APRV is another, or biphasic is another one that behaves like that. So those mandatory breaths will always happen, regardless that if you're breathing 10 liters of minute ventilation or 1 liter of minute ventilation, they will always happen. In type 2, whenever you have spontaneous breaths, the mandatory breaths disappear. That is, you can have rapid shallow breathing. You can now think about that, and you will not get those mandatory breaths under those circumstances. And so this is an important feature of this type 2. Type 3, mandatory breaths are only delivered when variable, and the one that has been described so far is using the minute ventilation. When that is below a preset values, the mandatory breaths will come in. But you could imagine that you could set this up to be another variable. This is how it has been done at this time. It's a target. And then the last one, type 4, is when mandatory breaths change to spontaneous breath by inspiratory efforts. And there's only one mode that we know about that does that, which is volume control with dual targeting on the servo, meaning that the breath gets triggered by the patient, and then because of the length of the inspiratory time or the tidal volume variables, they have some criteria there. You may end up with a breath that is cycled by the patient rather than the inspiratory time, and that makes it a spontaneous breath, and so that becomes a type 4. Alrighty, so that's just the background of what is out there, and then you can see that essentially there's a lot of modes that you may not have thought that they were IMV, but they are IMV on our practical daily life. And so that's for you to be aware of. So let's start with the first one. This was a image that was sent from us from Scotland by Richard Bolt, and he sent it directly to me to discuss, and I thought that it would be a good way to start today. And so I'm gonna publish the poll and start filling it up based on what you think this mode actually is. What is the tag? What is the load? And any patient ventilator discordance that you will see. And I see a couple of you are starting to answer this, the poll. Have no fear. And I will ask if any of my fellows or respiratory therapists are inclined to jump in to read this waveform. If you do, please unmute yourself and say hello. And if not, I will do it. I'll let this run for a couple of, one more minute as you're answering. test yourself. There's no good, this is the moment for you to try to read these waveforms. So test yourself against the rest of the team. Okay. Gonna give you 30 more seconds. Okay. All right. So polling has ended. Anybody wants to read this one? Or I'll go over the answers. Okay. So let's go over the answers and then I'll read this one. 6 of you thought that this was pressure control CMB with set point. A good amount of you thought this was PCIMB SS, so pressure control, intermittent mandatory ventilation with set point, and we'll talk a little bit about the taxonomy of this. Majority of you thought this was a load that was resistive. In terms of trigger, there was early or reverse trigger detected by several of you. In terms of work shifting, there was some work shifting detected, and in expiration, it was normal well, actually, it was split between normal and expiratory work. So let's go over this. Again, if anybody wants to read this, just put it on the chat and I'll call you in if you're interested. Okay. So what is the tag for this setting? What you initially see is that the pressure is flat. The waveform has exponential decay, and you can see that there's changes on the flow waveform over here. So this cannot be volume control, so it has to be pressure control. After that, we see this one, and this ventilator in particular, which is a Drager B800, puts this little mark over here that tells you that that's a patient trigger breath. And so you can see that these ones over here don't have any deflections on the pressure waveform or on the flow waveform, which then makes them mandatory. And because we see a spontaneous breath occur here, although there is no pressure given by the ventilator, there is a spontaneous breath that occurs, and the machine is telling you that. So I would agree with that setting that this is IMV, although you could potentially tell me, Eduardo, I think that this is a missed trigger or failed trigger on this patient, but the flow actually went up. So I'll talk a little bit about the settings on this patient. And the way that we use the tag for these groups is for the mandatory is the first one that we put here. So, sorry. So it's the first S is for the mandatory breaths. And then for the second, for the spontaneous breaths is the second targeting scheme. So in this case, it's SS for this particular patient on this mode. The mode for, in this case, was SIMB, pressure control, what the patient was on. And we'll talk why there was no pressure during these breaths. The pressure support port was set as 0 for the spontaneous breath. So this patient did not get any extra support as he was trying to trigger an extra breath here. So this is a mandatory breath, a mandatory breath, a mandatory breath, and then there's a spontaneous activity here, and then there's another spontaneous breath over here. So what is the load? Remember that during pressure control, what we look is the time constant. And so how long does it take for the patient to go from the beginning of inspiration to end inspiration, and if it reached zero flow. And actually you can see that during inspiration and during expiration, the flow never reaches zero. And so it seems to be a prolonged time constant. I don't have the scale of time under this set of breaths, but it seems to be that if I had to do a guess without a time scale, I would agree that the main force is resistive for this breath, for this breath, for this breath, and this breath. And then on this one, there's evidence of PMOS, and that is, you see, instead of you had the nice exponential decay, and at the end of it, you see how the flow rises, which is indicative that this patient is having activation of the PMOS. And the same over here, instead of having a nice exponential decay that you would expect just like that, there's all this activity, which makes us think that this patient is having, that this one is PMOS. So in general, I would say that the main load, if I had to talk about this, is that this patient has a resistive load, and you should be considering if he has or she has an obstruction feature, obstructed ET tube, COPD, emphysema, asthma, you name it. Then in terms of PV discordance, the first one is trigger, and we know that these breaths are machine triggered. So this one I cannot see the trigger on the first breath, but this one is machine triggered. This one is machine triggered. So they seem to be normal trigger for the first breath, or the first one I can assess. And then on the second breath, you see a mandatory breath, but you see evidence of patient activity there. So I see this is all patient PMOS. So when the ventilator triggers first, then the patient, that is called early trigger. So there's one early trigger right here, also known in the common literature as reverse trigger. I don't see a late, I don't see false, and as I commented, this could be understood as a false, but it's not a failed. It's just the fact that there was no pressure support for this patient. During inspiration, no work shifting, and then minimal work shifting due to the discordance, the early trigger. In terms of cycle, there's no PMOS here, so we would call this normal, the majority of them. This one, obviously, there's activity from the early trigger. And finally, in expiration, is normal for 2 breaths, and one of them has expiratory work. So I would call it normal. So in this case, you have early trigger. Now, there's work shifting without a doubt. So somebody may come and say, Eduardo, the spontaneous breath, there's work shifting. And I would tend to agree. You see, this is one spontaneous breath. So the patient did effort from here, from here to here, and then was going to exhale and had another breath triggered. So I think that there's some degree of work shifting. And so if we classify this PCIMV-SS, this is a type 1, and you'll see that on our notations that we actually, the way that we write it, we write PCIMV in parentheses 1 S, and that tells us what type of targeting scheme for IMV are we using. So Ariel commented, we have a longer TI with no expiration. I am not a Draeger user. Yeah, so that's fair. So one of the comments that Ariel poses is, well, Eduardo, you may have set up the expiratory time too short. Oh no, I see what you're saying is that we have a longer TI with no expiration. So all of this is a big inspiratory effort. Thank you, Ariel. Yes. So he triggered actually here another breath on the machine, and he continued to generate flow. So it's a very big inspiratory effort throughout. Thank you, Ariel. Very good. Questions there from the team? Any concerns? So let's move on to the next one. We have another one also from Richard Bolt. He sent us this one, and this may make a little bit more help to us to understand what we're seeing here. And so if anybody wants to jump on this one, go ahead. And if not, I'm going to pull out the poll for all of you to enter. And the poll should be live now. All righty, 13 people are on it. Okay, I'm going to close the poll 20 seconds. So as you start finishing. Okay. All righty, so the majority of people, I think I caught it too early, thought that this was PCIMV SS. Actually, I just realized there's two answers with the same. So everybody thought that was the case. There was an early trigger. People thought that there could be an early reverse trigger. Essentially no work shifting or to some work shifting, and normal to some expiratory work. All right, next time I will leave it longer. So this is actually the same patient, same mode, but something changed on this patient. So it's PC, again, IMV, S, so type 1, SS. And what you see on this patient is this is a spontaneous breath. So everything that goes above the zero line on flow is inspiration. So this is inspiration and this is expiration. And again, this is inspiration with a little bit of expiration, and inspiration again, and expiration. And if you try to assess the load on this patient, you actually don't see any exponential decay except on this one. And so this is one of those situations in which I cannot read if it's elastic or resistive, because PMOS hides everything. It's very hard to ascertain if that's what is the time constant when there's PMOS. And so I cannot make a statement about that. In terms of trigger, well, this breath got triggered. I can barely see a little bit of a depression on the trigger up there, but it triggers and it goes into expiration. You can see the tidal volume, how it goes. And then as the patient is exhaling, the patient gets a inspiratory, a mandatory. This is a mandatory breath. So this is a spontaneous, and this is a mandatory, and this is a spontaneous. And we know this is mandatory. First of all, we don't have the marker for spontaneous breath. And number two, there is no changes on the pressure waveform or flow that indicates me that this patient did any effort to trigger that. So that's why this is IMV. Again, in this case, the patient was getting 0 pressure support. So you can see that the patient is breathing essentially on CPAP, on the PEEP level that he was set, and then he gets the inspiratory breath. So the trigger for both breaths seems to be normal. I don't see any issue. Somebody wrote about an early trigger, but I don't see really any evidence of PMOS right here, so I cannot say that. In terms of work shifting, essentially the patient is doing all the work and the ventilator is not doing anything. So there's work shifting. The cycle, at least on this breath, seems to be normal, and this one is perfect. It's cycling with the patient, so it's normal. And then there's expiratory work, as you can see here. It's not the natural decay that we would expect. So there has to be, this patient is actively breathing in and out through it. So often when I would ask the team, so Ahmed asked me, I'm inclined to say this is early cycle and not early trigger. Yeah, good point, Ahmed. So the question often comes is, if the flow has not reached 0, is this early cycle, right, Ahmed? That's where you're inclined to say, because this didn't reach 0. So the answer to this is, when you're talking about patient ventilator discordance, there has to be a patient activity there. And if there's no patient activity, meaning the patient was not doing any PMOS, then there's no reference for this. So what is left is, yes, this may be that you cycled early, but it's a setting that you put. It's not necessarily a patient ventilator interaction. And so that's why I tend not to grade these as early cycles, and I focus on the ones where there was patient activity, and those look normal. Does that answer your question, Gohar?
Can I say, though, that maybe the fact that the patient triggered a spontaneous breath before the expiration was done with that mandatory breath is an evidence of PMOS that resulted in triggering that second breath and breath stacking in a form?
Yeah, that's a great point. So what you're talking about, Gohar, is when now that we're learning more about reverse trigger, there's different timings where reverse trigger or early cycle can occur, right? So does it occur during the inspiration period? It could happen in the first third, in the middle, in the end. Or there's many times, and we see this a fair amount of times, that it occurs in actually the expiratory period, and it occurs in the early phase of the expiratory period. So that may be it, and but I cannot necessarily say it by looking at this. So we're learning more about early trigger, and it may be that we need to actually start classifying where it happens in the breath, because it does have different consequences for the patient depending on where it happens. So excellent point, Ahmed. Thank you. Can you explain how you determine the third breath is spontaneous? So 1, 2, and this is the third breath. How do I know it's spontaneous? The first one is because I know that the patient triggered the breath. There's no pressure being delivered by the ventilator, and then it cycles off. So the patient is determining the start of the breath and the end of the breath. And if the patient determines the beginning and the end of the breath, that's called a spontaneous breath, Russell. It seems like you could characterize the inspiratory load on the mandatory breath. Can you not? Yes, that's a good question, Martin E8. Can you determine the inspiratory load on this one? And you could potentially say that this is definitely a resistive load. So you could suspect that. In the other two, I cannot. And usually when I'm not sure about it, I hint about it, or I try to look at my expiratory waveform. But because I see evidence of PMOS, I stood back, Martin. But great point. Ariel Garnero states, do you think that the small expiratory flow is caused by the circuit decompression and not by the patient? It could be. Sometimes you can have, as the load goes, the breath ends, you can have expiration, a small expiration, but the patient is doing inspiratory effort at that time, and it just hides it. So good point. Moha says, how you explain the change in volume waveform, it tipped down. I presume you're talking about this one over here. I don't know which one. You're going to have to unmute and explain me a little bit. You said yes. So that's a great point. Remember that the volume waveform is displaying what the patient inhale and exhale, and every ventilator manufacturer, there's not a standard, determines inspiration and expiration volume in a different way, and then they reset and you get it back in. So it seems that the patient inhaled. So you see this, this is the maximum during the mandatory breath. Then the patient started exhaling, and then the patient starts doing effort to inhale, right? And so the volume, it captured how the volume was starting, but then the machine detected a new breath started. And because it detects a new, the rule is that this moment over here is the start of a new breath. So because the ventilator will display the new breath starting from 0, it does this rapid drop because it starts again from 0 and it starts counting again. So what you're seeing here is that the patient was exhaling, and there was a little bit of, he started doing effort and crossed the 0 line, and boom, it went through, which goes towards what Ariel is thinking is, well, maybe this is that the release volume of the circuit, although it seems pretty large, it's hard to know. I mean, it's a liter here, so I don't know how much was that. The total BT of a breath in the right seems to be close to a liter, which could be a lot. I mean, that's one of the problems whenever the patient determines the tidal volume, right? That they can have as much tidal volume as they wish. So whenever I see this, so we can say it's early cycle. Not really. Are you? Moha, I don't know which one are you talking. Are you talking again about the same breath? It's already exhaling. So if the patient is exhaling, that cannot be early cycle. So it seems that the patient started having effort right here, not before that. So then this is the beginning of a breath that started around here and it ended up around here. Make sense? All right. So let's talk. Whenever I'm thinking about modes of mechanical ventilation, I think which would be a good patient. What goals does having a mandatory set rate, a mandatory rate that will always happen, all right? In which circumstances would that mode make sense? Would it be in safety or comfort or liberation? So I would ask the team, the group to just put their, in which circumstances would you use a mode of mechanical ventilation? Just a poll of hands if you make, so I see safety. And I presume this is, remember that safety covers mandatory, so maintaining a minute ventilation, a minimum minute ventilation, and preventing ventilator-induced lung injury. So yeah, I see that that's usually how the thought process comes. Is I want to ensure that this patient is getting a mandatory minute ventilation, that he will not get less than that. However, it comes at the expense perhaps of some synchrony issues if there's spontaneous breaths, and this will always happen. Or at the expense of giving too much minute ventilation if patient is breathing on top of that and they're getting mandatory breaths at all the time. So, all right, let's take a look at the next one. This is one of our patients. I will ask again, is anybody want to read this one? Go ahead and unmute yourself. I lost my poll. Here it is. So let me restart the poll. Okay, I'll give you a little bit more time to answer this one. Sorry about the last one. I know some were still writing. Oh, I put it in front of the, there. This one, I was walking through the unit and I was approached by our high quality respiratory therapist. It was 5 o'clock in the morning. I said, Eduardo, I have been working on this patient for the last 8 hours. It's been just impossible to get better coordination with the patient. And so we took a picture, we did some adjustments, and we'll show the results. And this happens often. I mean, I imagine these patients, they are connected to the ventilator and they're having an interaction, or they build a relationship with the ventilator. And it's like when your daughter brings the boyfriend for the first time to your house, and you just see them for a little bit of time, but not throughout the relationship. So you just see what you see at that moment, right? And you have to judge and create a best plan for these patients throughout. So, alrighty, 15 people are still doing this, so keep at it. So when I think about that under those circumstances in which you just have a eye view of what's happening to this patient, and the main issue is how the ventilator and the patient are working. The thought is, what modes can help us deal with this in a way while keeping our goals, either safety, comfort, or liberation. All right, you have 20 seconds to finish your answers. All righty. So does anybody want to read it, and then I'll go over the answers, or I go over the answers?
I can go, Dr. Morales. This is Aman.
Hey, Aman. Thank you. You like this one, so go at it.
All right, so I say the tag is PCCMVS.
Okay. Oh, sorry. Go ahead. PCCMVS.
Yep, so the flow is not controlled and we have a constant pressure level. So the load, I would say, I'm going to look at the second breath, which seems like a totally passive breath machine triggered. So looking at this one, the time constant seems pretty low. I'm going to guess elastic during inspiration. Expiration, trying to find a totally passive, it's difficult. Maybe the last one is totally passive. It looks about okay. It's maybe 1.2 seconds. So I'm gonna guess elastic in this one too. So PV discordance for the trigger, I see a few missed triggers on the flow profile there. So failed trigger. Inspiration is a very minor work shifting overall in some breaths, very, very mild, nothing impressive. And then cycle is looking at the first couple breaths, it looks like late cycle and the flows coming to the baseline. And expiration, I don't see a lot of expiratory work, so I'm going to say normal. And then I would just comment that it's probably the discordancies are linked because of the long eye time and late cycle. It's probably why the patient is having missed or failed triggers. Is because the patient is initiating a breath soon after the first breath is terminated. So I think this is one thing we can do in here is shorten the eye time, or I think the easiest thing to do, depending on the goals, is to switch to PCCSVS.
Thank you, man. Appreciate you jumping in. So absolutely, this is CMB. All breaths are mandatory. So this is mandatory because it's triggered by the patient, but it's cycled by time because that's why there's this pause here. This is mandatory because it's triggered by the machine, so immediately becomes mandatory. This is mandatory because it starts with a patient breath, and this is the second is patient trigger, but it's mandatory because the flow went essentially to zero and then it triggered the next one. So this is definitely CMBS. I agree with your reading. It seems like elastic. You see how rapidly it goes down, and perhaps on this one is the same thing, although there's some effort here. So this patient seems to have that. In terms of triggering, I will point out this is a pressure trigger. You can see the change in pressure here. And you detected appropriately a failed trigger, which is this one over here, right? You see that how there's a drop, there's a rise on it actually even crosses the threshold, but it's unable to trigger a breath because it's on a pressure trigger. And that's whenever I see pressure trigger, it's a red flag for me because that means that they are having issues with triggering of the breath by something else, either the patient or some other signal is doing it, because usually all our RTs favor, and we clinicians favor flow triggers. So whenever I walk and I see a pressure trigger, either it's somebody put it wrong or there's something that is concerning. And there's another mistrigger over here. You can see that Aman. So there's one failed trigger, two failed triggers occurring. And then on this breath has the classic pattern. This is a mandatory breath. And you see evidence of PMOS in here. So that becomes a early trigger. So you have failed and early trigger on these two breaths. In terms of inspiration, work shifting, I agree with you. There's some work shifting here on this one, In terms of cycle, the key feature is late. Actually, you can see this breath over here, how it's late cycle, late cycle, late cycle. This one is actually, well, it's an early trigger, so you cannot see it, but it was going to be a late cycle. And so without a doubt. And finally, the expiration, there's some work, but mainly normal. It's all these missed efforts that are occurring. So I asked so let me see what people ask. So PC, all TI same to be the same. So mandatory. I don't see any spontaneous. Yes, Ariel. I think there is early cycle in the first breath, miss trigger in the second, and reverse trigger in the third. Okay, Mariam, let's see. Early cycle on the first breath. No, if it was early, it would have ended up earlier than the patient. So it would have ended up around here. So it's late because it ended later than the patient.
My question is, like, during expiration, you see that the patient, and it's during early expiration, patient is trying to trigger the breath again. It's going almost. So I was under the impression if that happens, that's the pattern we see with early cycling. Like, how do you differentiate is if it's early cycling or is it a missed trigger?
This thing over here?
Yes.
So that's a missed trigger. So early cycle, usually what you would see whenever you have an early cycle is you will see the flow go up, and then usually there's some PMOS, so you'll see something like this. Then the breath ends, and then you're going to see it like that. Here, what you see is there's no flow or minimal flow. Then there's exhalation, and then there's the effort here. And so the patient had finished its effort here. And so if you imagine his PMOS, let me put it in red so that you can see the PMOS. So he triggered this breath and he did this. And then he exhaled and did this, another breath. And then there's nothing here. And then he has another breath here and another trigger here. Does that make sense? So this patient was very desynchronous with the ventilator. So the question that I had for the team when I came to the bedside was, why have you tried pressure control, pressure support for the patient? And the answer, and I'll show you the reaction to pressure support, but the patient would hypoventilate, or it would go really fast on its rate, which it seemed to be due to a problem that you'll see in a second.
Can I add a quick comment or question?
Yes.
Kind of on the same point that Mariam is wondering about. So I would, like in my mind, the fact that we have like early cycling, like the nice waveform you drew there.
Thank you.
You could still have early cycling, yet an ineffective trigger. Let's say this effort that was done because of the early cycling almost reaches the baseline, or does reach the baseline without triggering a stacked breath. That would be a missed trigger as well, correct?
Yes. So great point. So when you think about the causes of, so if these had three, so let's put this one over here. This one, you can see the effort from the patient, right? So, or actually, let's put this one here. This is an early cycle, a classic early cycle. If the patient had gone all the way up and triggered another one, the patient would have gotten another breath here, like that, right? And this would be the two breaths or multiple triggers, two breaths, one after the other. In this one that it's over here, you had, so whenever I say something is early cycle, there has to be still flow at the end of the breath, and there's no flow here. If there's no flow, this cannot be early cycle. Does that make sense, Gohar?
Correct. Yeah, what I'm saying, I mean the fact that there's an inspiratory pause of some sort there, that there's no flow, it's an indicator of late cycling. But what I'm trying to say is you could have an ineffective trigger secondary, or like you could have basically early cycling that may either result in a breath stack, or you could have an early cycling that could result in just, you see the effort like this waveform you drew without any issue, or you could have an early cycler that results in patient effort, but it then ends up with an ineffective trigger as well. But it's always important to figure that the pathology here is early cycling, so that when you're trying to make adjustments, you know that what you need to is to increase the eye time if that is acceptable from safety standpoint.
Absolutely. So you touched on a good point. So if you think about early trigger on its own, and let's say that the flow didn't look like that, but it looks something like this, and the patient does an effort here. You have seen that, right? And then, so technically, this is an early trigger. It started over here, but the machine is also early cycling because the patient is still doing effort, and then the breath ended, and that's why you get the extra one. So these desynchronies, I use the one that the primary one as the cause. They will come mixed with others. So this is early cycle, but it could be read as a missed trigger, but the cause is actually an early cycle. It's not a missed trigger per se. Does that make sense? I will take that silence as a yes, or I give up. Okay. Oh, I see your answer. Okay. Inspirator pause is always suggestive of late cycling. Yes. Thank you for writing that. All right, and I answer Marco's question. So fabulous. So what we decided to do is we switched this patient. I want to show you this waveform, which is essentially we put the patient on auto mode, and auto mode, the tag is PC IMV. It's type 2 and is SS. So it's essentially what was happening to our team is every time they would put the patient on pressure control, the patient would have what you just saw. Whenever they put it on pressure support, the patient would at times hypoventilate, or actually would have they were triggering another breath. So she was having two triggers. So you can see here is that the flow is ending at 0. or very low. And that's because we put the end expiratory sensitivity all the way down to 1%, because every time the patient would exhale, she would have this little sucker, and that sucker would come up, and every time it would come, it would trigger another breath. And so that, if you notice now, she's back on flow trigger, so it was easy for her to trigger. It's we extended the I time, and this auto trigger or false triggering that was occurring because of recoil artifact went away when we took away the end expiration all the way to 0. And we put her on auto mode because then she could be, whenever she fell asleep, she was on opiate drip, she would become apneic, and then the machine would kick in and would give her a baseline respiratory rate that it said here at 20. And whenever the patient starts breathing on their own, if they would go away and the patient would be breathing spontaneously. So technically freeing our respiratory therapists from having to be at the bedside throughout the time, and ensuring that the patient was getting a minimum minute ventilation, and while ensuring that she was synchronous. So we took away the I time issue and the triggering issue by doing that. And so questions about this?
A quick question. I've had trouble understanding how Automode works, especially in Servo U. I've noticed sometimes, I'm trying to read the manual right now, but it seems to me that it instead of the classic type 2 IMV, this one looks at the apnea time. So if the patient goes apneic for this, for a set period of seconds, then it switches to mandatory breath, versus looking at the respiratory rate, which is the definition of type 2. I don't know if you have any insight into this.
Yes, absolutely. So so you see it here. You see the value down here.
Right.
So as long as the patient is breathing and the expiratory, actually I put here a little there. This is the classic explanation. This is the patient actually. So you can see that the patient was not getting any breath for an amount of time. And when the patient did not achieve that breath, she got a mandatory breath, and then exhales, and then wakes up and says, okay, it's time for me to breathe, takes a big breath, exhales. So without a doubt, it uses the marker, and we're still learning about all these modes because they may have hidden algorithms, but the main one is that if the apnea time, that amount of time elapses, the breath will trigger. And Rob could not be with us today, so they have to come over. And so we're having here a comment from Ariel, who has done this. It says, so you change from PCAC to Automode, PCPS. So from PCCMBS to PCIMBSS, Automode has another combination too. Yes. The trigger time out from 7 to 12 is the waiting period for a spontaneous breath to appear. If not, then they start sending mandatory ones. That's correct. So I hope that answers your question. But this is the variable. I used to think as you are, that it was the respiratory rate. So if the patient had an expiratory time that was that he was not getting that amount of respiratory rate, and then he would get a mandatory breath, but that's not the case. It has to do with them not breathing for a certain amount of time, and then they trigger a mandatory breath.
Right. Okay. Thank you.
No problem. I wanted to show. So this is the other type. This is type 3. Type 3, and in this one, which is mandatory minute ventilation on the Draeger. Well, and this graph I like because I think that it highlights what we're talking about. Is you have the patient is sedated and they get the mandatory minute ventilation, and as they start breathing on their own, they as long as if they're not meeting the goal, the set minute ventilation, they will get mandatory breaths, and when they're doing all on their own, the mandatory breaths disappear. So this is another implementation that you can imagine, that you have specific patient, perhaps coming out of anesthesia, in which you want them to progress from being fully dependent on the ventilator all the way to being spontaneously breathing. So it's another implementation of type 3. So with that, I want to see if there's any other questions from the team. I'm going to put here the CME code for a little bit. And again, here is the CME code in purple. And then in blue, you have the SEVA webpage for all of you that want to share with the universe what we're doing. Please do so. We're learning. I mean, as you can see in any one of these things, we start bringing out things that we could not see. And so send us your waveforms. There's ventilators that we don't have here that we would love to see the screenshots. A shout out to Mexico. I see Dr. Sierra and Dr. Jean-Paul, Marco from Canada, Sweden, all of you. Thank you for joining us and being part of our training sessions. We learn a lot together. Okay. With that, thank you.